Hi there, this is Renzo Cataldo. I'm an electrophysiologist at Biltmore Cardiology. The heart has 4 chambers. There are 2 chambers on the top and 2 on the bottom. The bottom chambers are the main pumping chambers of the heart. Under normal circumstances, there's an electrical signal that originates over here in the top right chamber of the heart, makes its way over to the top left chamber of the heart so that both chambers can be electrically activated and squeeze blood down below. Then that signal makes its way to the middle of the heart in an area called the AV node, which is kind of an electrical bridge between the top and the bottom chambers of the heart, which are the main pumping chambers of the heart. The bottom chambers of the heart have a specialized electrical system that essentially allows for rapid and symmetric activation of the heart muscle so that the heart muscle can be electrically activated simultaneously and rapid. That's important because certain people require pacing devices that can specifically pace on that electrical conduction system. And that electrical conduction system, some people have something called a left bundle branch block, which means that this electrical cable that is heading down over to the bottom left chamber of the heart is not functioning very well. So the electrical system is not functioning well, and every heartbeat that makes its way over to the main pumping chamber of the heart basically is taking the slow road to China. All right. So what I mean by that is if you're driving along the highway, if you're driving along very rapidly and then there's a detour because of construction or something like that, and you have to take the side roads, you'll still get to your destination. You'll just get there slower. Right. And that essentially is the concept of what a left bundle branch block is. You'll have electrical conduction to go down to the bottom left chambers of the heart, but through one cell to the other. So every cardiac cell is capable of generating electrical activity and also spreading electrical activity. And that spread of the electrical activity is quite rapid with what the electrical conduction system is. But when that doesn't work very well, it has to go from one cell to the next, and it doesn't work perfectly. So if I were to show you a picture of the main pumping chamber of the heart with this left bundle branch block, the heart kind of rocks on the inside of the chest as opposed to squeezing symmetrically. What do we do sometimes? Sometimes people require what we call biventricular pacing, or otherwise called cardiac resynchronization therapy. What I mean by resynchronization is that we would make a small incision underneath the collarbone. We get inside the vein that runs underneath the collarbone, and we thread 1, 2, or 3 wires over to the inside of the heart, depending on the patient. One wire is placed in the top right chamber of the heart. One wire is placed in the bottom right chamber of the heart. And another wire is placed inside a vein that wraps around the bottom left chamber of the heart. So that way, the bottom right and the bottom left chambers would be electrically activated at the same time by these wires. These wires are then connected to a little device, which is then placed underneath the skin. That's the concept of biventricular pacing. But pacemakers can be placed for lots of different reasons. It could very well be that naturally occurring pacemaker in the top right chamber of the heart is not functioning to its best capacity, and the top chambers of the heart are sending signals very slowly to the bottom chambers of the heart, and therefore people will need a standard, what we call a dual chamber pacemaker. The other thing that can happen is there could be complete disconnection between the top and the bottom chambers of the heart at the level of this AV node. That's oftentimes a patient that we see coming in through the emergency department and actually feeling very, very poorly, or in sort of an emergency type of situation, and that's called complete AV block. Now, sometimes it's not just simply a pacemaker that needs to be implanted, but it's a device called a defibrillator. And a defibrillator is about half the size of a cell phone, and it's a little bit bigger than a pacemaker. A defibrillator is a device that does everything that a pacemaker does, but it has the added capacity to be able to shock the heart back into normal rhythm, right? If we see that there are patients who are prone to having really bad, life-threatening type of heart rhythm disturbances coming from the bottom chambers of the heart, and a defibrillator would be for that kind of patient. Placing a device like this is not major surgery. The incisions are usually about that big. What we do is we get inside the veins, thread these wires over to the inside of the heart, Once the wires are in good position, we can place a couple of stitches over here underneath the collarbone. We make a little pocket over here underneath the skin. We take this device, connect it to the wires, put it underneath the skin, and close everything up. The main things that can happen, number one, there can be an infection. There are certain patients who are prone to infections, diabetics, people with kidney problems, or people with prior infections. But the chances of an infection happening are about 1% or so. The chances of a catastrophe to happen is very small, but that's less than 1%, and that we can accidentally perforate the heart. There could be also a small chance, about 1 or 2% of the time, that as we get into the vein over here, we can accidentally nick the lining of the lung. And if that happens, the lung can partially collapse, and we would have to put a tube over here in between the ribs for a couple of days to help re-expand the lung. Also, other things could happen that are unforeseen, like blood clots in that blood vessel leading to the arm, etc. The main restriction that I have for people is not to raise their arms over their heads for about 6 weeks. So in case you're at the mailbox and you have to say yoo-hoo to your neighbors, do it with your right arm, not your left arm. We generally put pacemakers and defibrillators on the left side, but we can do it on the right side as needed. So the main restriction is not to raise their arms or not to lift anything heavy over, say, a gallon of milk for about 6 weeks, because those wires have to develop some scar tissue. And once the scar tissue has developed, then we can sort of liberalize the way people can move their arms around. Occasionally, people either unable to or cannot comply with the arm restrictions. And if that should be the case, then there are smaller pacemakers that we can implant via the crease of the leg inside a vein. They're about the size of a bullet. And these devices are implanted with tubes going on the inside of the heart. And different models have different ways of implanting themselves on the inside of the heart. But these little devices can actually pace the heart as a pacemaker ought to. We generally see patients in the office on a regular basis once a pacemaker or a defibrillator has been in place. And we have a crack team of people who monitor the devices here in the office, but also remotely, and the devices can communicate with us remotely as well.